here we go.
Welcome to Baptist Medical News Network. I'm Rhonda McRae. Thank you for joining us today for our live webcam. Our topic today is burping babies, constipated kids, and tummy troubled teens, or in other words, any kind of digestive issue affecting kids of any age. And joining us today to help us with that is our expert pediatric gastroenterologist, Dr. April Ulmer. Dr. Ulmer, thank you for being with us today.
Thank you for having me, Rhonda. I really appreciate it.
Yeah, we're glad you're here. We're going to jump right in just a minute, but first, just two housekeeping issues before we get started. First, if you want to post a question for Dr. Ulmer, you can do so at any time now. Go to our website at www.mbhs.org/mednewslive, MEDNEWSLIVE. Scroll to the bottom of the page, and then there's a form titled Leave a Reply. Just fill out that form. When you post it, in just a few minutes, it will appear on our webpage, and we'll get to those questions a little bit later, but you can go ahead and start posting your questions right now. Now, after you do that, in order to resume the broadcast, you'll need to go back to your viewer and hit the play button again, and that will launch the viewer again. One other thing, there are some ads that appear on the viewer as you're watching the live broadcast. Those are paid to Ustream TV. Ustream provides the live capability for this, and it's not affiliated with Baptist, so just be aware you will see those, and those are not Baptist ads, those go to Ustream. So with that, let's jump right in, Dr. Ulmer.
All right.
We're talking about tummy complaints for kids. Of course, that's a very common thing. Mom, my tummy hurts, very common. But what are some of the things that parents might not know about tummy complaints, aches and pains?
Some of the most important things that parents need to know is that even if the child doesn't complain of tummy aches every day or on a regular basis, the underlying cause can still be significant. So some of the things that they need to consider is whether or not the child is consistent in their complaint. They should also take note of whether or not there are certain things that seem to cause the child's pain. And also they should pay attention to whether or not their child seems to be withdrawing from normal activities, missing school, not wanting to play sports, and those types of things. In general, those are good indicators as to whether or not the tummy complaints are significant.
Okay, all right. So what would be a common example of something that would cause a child's withdrawal from school or normal activities that's related to a tummy pain?
Right. Well, some of the most common things that I see, and of course it varies by age, and we can talk about that a little bit later on, but you know, definitely things like gastritis or inflammation of the GI tract is fairly common. Lots of times what happens is a child might suffer an infectious insult. It could have been a cold or maybe even a viral illness that went pretty unrecognized by the parents. Maybe the child just didn't eat very well for a day or so. But sometimes the gastric lining, or the lining of the stomach, can become irritated. Now, the stomach is normally a bag of acid, and it's made to hold that acid, but if the lining becomes irritated, then the child might experience pain associated with the acid being there. This pain might be worsened by things like food, with stress, those types of things. So that's something that I see with some frequency. Just because it is simply reflux or gastritis, though, doesn't mean that it doesn't need medical therapy to heal it. Okay, so the key is to find out how long the child's been having trouble, whether or not the symptoms seem to be worsening. Like I said, whether or not he or she seems to be in significant discomfort or withdrawing from activity. If so, all those things are indications for treatment.
Okay. Well, let's jump ahead a little bit. Let's go ahead and break it down by age group. What would be sort of some of the common things you might see in infants, little babies?
Right. In infants, sometimes it's difficult because I do see a lot of first-time parents, or even parents who have other children. You know, there can be a lot of variation as far as the disposition of infants and whether or not one has reflux or colic and versus the other. So sometimes I come in, or parents come in to see me, and they just don't know what's going on. They have a baby who's really fussy. The baby might spit up, might not. So the question is whether or not this child might have reflux. And reflux is a fairly common entity in newborn babies. You know, and sometimes these babies, even though they're newborn or maybe a month old, do require medical therapy in order to make them comfortable. Now, it is important, though, to note that there's a difference between simple reflux and what we call GERD. GERD is G-E-R-D. And what that stands for is gastroesophageal reflux disease. Now, the pathology or the pathophysiology behind it is the same, meaning both are caused by stomach contents coming into the esophagus and sometimes even out as
Okay.
vomit. But the difference is in reflux, those are babies that we call happy spitters. You know, they might vomit, but they keep playing. They don't seem to be in any discomfort.
They're happy.
They're happy. They're growing well. And by and large, we try not to treat those babies with medicines because reflux is very common. And most babies outgrow it by 12 to 15 months of age. You know, the converse of that is if I have a child who comes in who is very, very fussy, associated with feeding, they're arching, they seem to be in pain when they do spit up, or they're discontinuing their feeds because it hurts, or their growth is faltering. That would be classified as GERD. That is when it's actually reached the disease state, and that's an indication for treatment.
Okay.
So definitely reflux and GERD are some common entities in babies. Another thing that I see in babies who are really fussy is obviously colic. Colic is one of those things where, you know, unfortunately, parents usually just have to wait it out. Most colic resolves by about 3 months of age. There is no specific known cause of colic. It's just a baby who's otherwise fussy. Fussiness tends to occur later on in the evening in most babies, and the baby's otherwise very healthy, growing well. Okay.
So they're driving mom and dad nuts.
Pretty
they're
much.
basically
But they're
okay.
fine. But they're fine. And so treatment of colic is more geared towards symptomatic relief. Some parents will tell you that they have to put the baby in the car and ride them around for hours, and you know those soothing motions are what help. And then the baby eventually outgrows them, and there are no real long-term implications associated with colic. The last thing that I see with infants is a cow milk protein or soy protein allergy or intolerance. That can actually cause abdominal pain, fussiness, bloody diarrhea sometimes in stool, as well as vomiting. Okay, and the treatment for that is putting babies on a more elemental formula. And then what that means is a more broken down formula.
Okay.
Because the issue is the babies are actually having an allergic reaction, or the gut is having an allergic reaction to the proteins in the formula. So for the infant category, those are probably the top 3 things that I see in infants.
So for the babies that's happy and spitting up, they're pretty much okay, they'll outgrow it, but if they're resistant to food, maybe not gaining weight, come see you.
Absolutely, right away. You know, I tend to be really aggressive when it comes to young babies, especially if they're not feeding properly, they're not growing properly, because they are so young and they don't have the same reserves that older children have.
Okay, well let's move into older children and maybe define let's define the age. Infant is considered birth to
about 1.
Okay.
Typically is considered infant, because like I said, with 1, that's when you tend to outgrow things like protein allergies, reflux, and obviously, like I said, colic. They usually outgrow that at about 3 months.
Thank goodness.
Yeah, thank goodness. It's a long 3 months. But birth to 1, from about 1 till school age, about 5 or 6 is the childhood phase.
And what do you typically see in that age group?
In that age group, I still do see quite a bit of GERD, and like I said, these are children who have outgrown reflux as an infant and might not have had any additional issues, but then they might get an insult, like a virus or an infection that irritates the GI lining or the GI tract, and they might develop gastritis. Okay, so those are kids that come in with tummy complaints because of an acid issue. Even children that are very young can develop ulcers as well. Okay? So lots of tummy complaints because of that. I also see bacterial infections with some frequency. H. pylori. H. pylori is a bacteria that tends to cluster in families, and we used to think that ulcers in kids were primarily from stress, just like in adults. But now what we know is there's a very high correlation between an H. pylori bacterial infection and ulcers. So sometimes I have children who've been infected for a while, but it's not till they're 5 or 6 till their symptoms get severe enough to bring them to see me. Okay, so I see a lot of that. Also with that age group, you start to see things like celiac disease as well.
Okay.
Celiac disease is a reaction to gluten. Gluten is a filler. It's a wheat, rye, and barley byproduct that's used as a filler in lots of foods in order to enhance the flavor, the texture, the nutritional value with protein. But what we know now is that certain people are genetically predisposed to not tolerate gluten. So the small intestine has a sort of allergic reaction almost to gluten. So there are lots of associated complaints, abdominal pain. Some children have issues with diarrhea, vomiting, not growing well. Okay, so I do start to see that. Classically, you're supposed to start seeing gluten intolerance in about 1 year of age, but I see it at any age group.
Okay. And the symptoms there are pretty obvious.
Well, sometimes. What we know now is that if a child is diagnosed as a toddler, around 1, they're more likely to present with diarrhea due to celiac disease.
Okay.
But as a child increases in age, and especially once they reach 10 years of age or older, they're less likely to present with those classic symptoms of faltering weight gain, diarrhea, those types of things.
Okay. So older than age 10, is it a little trickier to diagnose?
Absolutely, absolutely, because they get into the tween stage. And definitely in each age category, kind of like we've been talking about, there are certain diseases that you see most commonly. But once you reach 10 or so, it could simply be reflux, or you also get into things like celiac disease or even inflammatory bowel disease. And so I think that's a nice segue into our next patient population, which is my adolescents. With adolescents, we do tend to worry more about things like inflammatory bowel disease, meaning Crohn's disease, ulcerative colitis, and what those are chronic inflammatory conditions of the gut.
Oh dear.
Yeah, they're lifelong conditions. They are treatable with medications, but they can really present in any way. You know, a large percentage of my patients do present with abdominal pain, but not all of them. Some simply present with bleeding, with difficulty gaining weight, with vomiting, those types of things. So part of the difficulty with the disease sometimes is making the diagnosis. So it might require more than one visit, it might require blood work, might require endoscopy or the scope test in order to diagnose it. And one thing that's really nice that we offer in our practice for children, and we're the only one in this area that offer it, is the pill cam test.
Okay, tell us about that. Tell us about what procedures or tests you might typically do on kids, including that.
Right, okay. Some of the most common procedures that I do on kids are the endoscopy or EGD, that's the upper scope test, and the colonoscopy, which is the lower scope test. Now for the upper scope test, and that's a little test where I take a thin tube that has a camera and a light on the end of it, and under direct visualization I actually go in through the mouth and go all the way to the stomach and out of the stomach a little piece into the small intestine called the duodenum. Now the child's completely asleep for this.
Okay.
Yeah, and the test takes me on average about 5 minutes. It gives us a lot of information for various reasons. The first reason is because I can actually visibly inspect the tissue. I can tell you whether or not there are ulcers there or anything else that looks abnormal. But the biggest value of the test is that we can perform biopsies.
Okay.
Biopsies are tiny, almost microscopic pieces of tissue that we take. The child never knows we took them. But we send that to our pathologist, who's a doctor who looks at it under the microscope, and that's how we diagnose inflammation or irritation, bacterial infection, celiac disease, or inflammatory bowel disease.
Okay.
The colonoscopy is a similar test. I start at the rectum and I drive the scope all the way around the colon, okay, visibly inspecting it and also doing biopsies as well.
And the child is asleep for that as well?
Completely asleep. The lower test usually takes me somewhere around 10 minutes. Sometimes it actually takes longer to get them asleep and get them in position than actually do the test. So the children do really, really well. They tolerate it well, and both are procedures that are relatively low risk and do provide us with a lot of information. Otherwise, we'd be left to guess a lot of the times. The last thing you mentioned was our pill camera, which is very exciting because we do use it quite frequently. Sometimes, especially in situations like inflammatory bowel disease or Crohn's disease, which is inflammation that can occur anywhere in the GI tract, children can have inflammation or ulcers in the small intestine. And the small intestine, we can't get to every inch of it with the scope. So what the pill camera allows us to do is have the child come in, they swallow a capsule that's actually a camera. And as that camera moves through their body and their small intestine, it actually sends photos at about 20 per second to a belt that they wear for several hours. Once the camera is finished or it's completed its journey through their bowel, they drop the belt back off to us. We download the pictures, and it's really neat because that camera takes so many pictures per second. When we view it, it doesn't look like pictures at all. It actually looks like a movie. So I take a journey through their small bowel. I can look for any abnormalities such as ulcers, and like I said, it really provides a lot of information. And we've actually, for children who had disease that was limited to the small intestine, even though maybe we had done the EGD test and the colonoscopy and didn't find the disease, there have been several cases where the pill camera actually allowed me to diagnose those children and get them started on treatment sooner. So it's very nice to be able to provide that for the people of the state of Mississippi.
And I guess the kids tolerate that very well too.
Absolutely, absolutely. They never know it's there. You know, they swallow it,
pill,
and that's it. Absolutely. And then and that's really indicated for children 5 years of age and up.
Okay.
I know that some patients, or some of my kids, even though they might be older, they might be 15 or 16, they don't really swallow pills very well. And so one option is, when we have a situation like that, sometimes we can actually place the pill endoscopically. So we actually do another quick scope, and we actually introduce the pill into the stomach for the child. which makes it nice and easy.
If they don't like swallowing the big
Absolutely,
pill.
absolutely.
Well, Dr. Ulmer, I'm going to pause right now and refresh this page and see if we have any questions. So excuse us 1 second while we do that. And refresh. Okay, we do have some questions. Jason says, my daughter has lots of gas and complains her heart hurts, but it's like her heart is racing at times. Could this be GERD?
I think it absolutely could be GERD. Now, the most important thing, though, to realize is that sometimes, just like I said, you have kids who complain of various complaints. GERD symptoms can look like other things as well. Okay, so it could be GERD, and definitely that's the most common thing that we see in otherwise healthy kids. But there are other things that can look like GERD. Namely, if the child has an ulcer, then that's really the problem. The stomach gets really twitchy, the stomach lining, and it sends acid into the chest. So the actual problem might be that your child has an ulcer, could have a bacterial infection that's causing the symptoms. Even children with celiac disease can present with GERD-like symptoms, but the underlying problem is actually gluten. So I would say that your child's symptoms are more consistent with possibly esophageal inflammation. The question is whether or not it's truly an acid problem, whether it's a food allergy problem, whether it's something like celiac disease. One thing that you can try is to give her over-the-counter antacids like Tums or Mylanta and see if that improves her symptoms. If so, then that confirms the idea that this is due to inflammation or irritation of the esophagus. But the key is going to be getting the acid problem, if that's what it is, healed, or whatever other entity it is healed. And that's really what's going to prevent recurrence of the symptoms.
How will he know when to see the doctor?
Yeah. Well, if her symptoms are occurring frequently, even if they don't have a specific pattern, even if food doesn't bring it on and you can't associate it with anything in particular, or like I said, if it's limiting her activity, you know, if she just lies around on the couch when she's having symptoms, or it seems like she's generally having a hard time with it, you can never go wrong with seeing the doctor. You know, it's always, I always tell my parents, you know, if you're worried, I'm worried. I'd rather see your child and say that your child is otherwise healthy, or just start them on a little medicine and follow up with them once or twice to make sure that they're completely better, than have them out there having trouble for a long period of time. Another thing to consider is, if this is, say for example, if it is just GERD, if it's an acid issue, sometimes by the time kids get to me, they've had this issue for several months, and so the inflammation is a lot deeper, a lot more significant than if they would have come to see me sooner. So sometimes they require stronger medicines, sometimes they require procedures to confirm the diagnosis, because maybe the frontline medicine, the first-line medicine won't work anymore because the inflammation has become so significant. So the sooner, you know, a good rule of thumb is the sooner you get her in to see me, or to see the doctor, the sooner the child can get diagnosed, get on the medicine, get better, and hopefully get off the medicine sooner.
Sooner rather than later.
Right, right.
Okay.
Because it's always better to catch it, to cut it off earlier.
Right. Thank you, Jason, for sending that question. I think we've got some more here, so let me check this. Christy says, what are some examples of gluten-free foods?
Wow,
Big question.
That's a big question, Christy.
Thank you, Christy.
Yeah. One of the issues with gluten is it tends to be in lots of things. So an example of a food that has gluten, obviously, is bread, but also things like self-basting turkeys, gravies, lip gloss, lipstick, lip balm can have gluten in it, cookies, candies, medicines. So I don't think there is an answer. The key is to learn how to read labels. Okay, that's really the key. Anything that has obviously wheat, rye, barley, okay, is going to be a no-no. But also, you know, there are other trigger words, and typically when I diagnose a child with celiac disease, or if we're going to try the gluten-free diet, I actually give the parents a packet of information and also refer them to a nutritionist so they can sit down and kind of go through an example of a gluten-free diet. By and large, the less processed a food is, the better in terms of being gluten-free. But like I said, there is no one answer. Now, I have patients who come in and they give me information all the time about things that might be naturally gluten-free. For example, Fruity Pebbles, they tell me is naturally gluten-free, and I would not have known that. Certain fish fries like Zatarain is naturally gluten-free versus other ones aren't. I actually had a patient tell me the other day that there's a brand of cheese puffs that is naturally gluten-free versus the other ones that aren't. And even some things like soy milk, for example, you wouldn't expect or to have gluten in them. One brand of soy milk, if it's the regular flavored, is gluten-free, but if it's the vanilla flavored, it's not. So, you know, the answer is there is no one answer.
Trial and error.
Trial and error, and actually getting good information. And that sort of brings us to another little segue.
Right.
You know, one of the things about celiac disease, since you had the question, is that previously we thought it was something that was relatively uncommon, with an incidence of about 1 in 500 in the United States, and we thought the incidence was more like 1 in 100 people in Europe. What we've realized recently, fairly recently in the last couple of years, is that the incidence or the occurrence in the general population in the United States, and this is people just walking around with no symptoms even, is about 1 in 100. Okay, so there are lots of people walking around out there who have celiac who don't even know it. For people who have relatives that have celiac disease, the incidence is about 1 in 20.
Oh.
So it's a very, very common disease. I actually diagnose it quite frequently. I have children from all over the state with celiac disease, and that's one of the reasons why this summer we decided to actually have a celiac disease conference for patients and families.
This is a good time to talk about that.
Okay.
So why don't you go ahead and tell Christy and everybody else about that conference coming up.
Okay. The conference is on a Saturday, June 13th at Baptist for Women. It's from 9 a.m. to 12 p.m. It's for patients and families with celiac disease. Lunch is provided. A gluten-free lunch is going to be catered in for the families. And one of the biggest reasons why we wanted to have the conference is because we wanted to pool a lot of resources for these families. Oftentimes, I do have questions like, what's on the gluten-free diet? I need more information about it, you know, and also, where can I find the food? What are some good recipes for bread, for example? So this is an opportunity for us to bring together doctors. I'll be speaking. Also, one of my adult partners will be talking about celiac disease and the long-term implications and why it's important to follow the gluten-free diet. We'll also have a nutritionist that's there to answer some questions and be available after the conference. We'll have someone from the Mississippi, the school system, okay, to talk about what are patients' rights in terms of having a gluten-free option at school. We'll also have an accountant there who's going to talk a little bit about how to code the food that you buy, because it is a medical therapy, so whether or not there might be some tax write-offs, some tax implications, and some good ideas for parents, because the food does tend to be expensive. So we'll have all those resources. We'll, like I said, have lunch provided. We'll have other vendors, so you can sample some of the gluten-free foods, which might be a good thing for you, because there are vendors that provide gluten-free options, but one of the problems is some of it your child's just not going to eat.
Right.
It has a different taste, it has a different texture.
Might not like it.
Might not like it. Parents tell me that it's sometimes relatively expensive, and they tend to waste money because you might buy it, and if your child doesn't eat it, then it's wasted. So it'll be an opportunity to get together with the vendors, and also, most importantly, with other parents. I have some parents who are very, very savvy as far as the gluten-free diet, and they can tell you things that are naturally gluten-free and also where they get their gluten-free foods. So I think it's going to be a really, really good opportunity for parents. It is important to register because seating is limited. The registration number is 601-948-6262.
And there's also an 800 number for that.
Absolutely. And so the most important thing is just to get registered and come on out, and then maybe we can have some additional information for you.
Okay, so that's Saturday, June 13th, beginning at 9 o'clock here at Baptist. And to register, you'll call 601-948-6262 or 1-800-948-6262. Christy, thanks for sending in that question about gluten. And excuse me, I'm going to refresh the screen and see if we have any more questions for Dr. Ulmer. So let me do that right now. Okay, we do have another question. Do we have to see our pediatrician first, or can we just call your office if we have concerns?
Actually, you can just call my office. You can just call my office. I see a wide range of problems, from just tummy aches to constipation to things that require more working up. So absolutely, you can call my office and make an appointment. I have great staff. Alice or Kristen will be happy to help you, get you on my schedule, coming to see me. The office number is 601-355-1234. You can just ask to speak to Dr. Ulmer's office, Dr. Ulmer's assistant, or if you don't remember my name, just say the pediatric gastroenterologist. I'm the only one in the group, so we'd be happy to help you.
Okay, all right. I'm going to just refresh one more time to see if we've got any other questions, and then we're going to get back to some of your good information here. Okay, we've covered all our questions so far, but you can post those questions at any time if you have any more for Dr. Ulmer. And Dr. Ulmer, we had talked about some causes of abdominal pain that parents might not know the causes.
Right.
Are there any others that come to mind?
Well, a couple of things also I want to mention is sometimes I have parents bringing their children who've been having abdominal pain for some time, and sometimes the parents say, well, I have a history of irritable bowel, so does grandma, and there's a long history of irritable bowel. It is important for parents to realize that in children, irritable bowel syndrome is really a diagnosis of exclusion, which means that if a child's having significant pain or symptoms that are causing them to withdraw and not do their normal activities, or pain that occurs fairly frequently, or pain that's relatively infrequent but that lasts for weeks or months, you really want to make sure that there's not an underlying tissue problem. So that's something that I try to impress upon my parents is, if we do the necessary testing, we do the necessary treatment, and it does end up being irritable bowel, then that's fine. We can teach the child some techniques to better handle stress and those types of things. But I always caution parents not to automatically assume that it's just stress-related or it's just quote-unquote irritable bowel syndrome. Another thing that I tell my parents is sometimes parents are very astute and they notice that the child's symptoms worsen when they're stressed out or when there's a big test or they're really excited about something. It's important to note that if there's underlying inflammation or abnormalities of the GI tract, oftentimes symptoms will worsen with stress, but oftentimes stress is not the primary cause of their symptoms.
There may still be something.
Oftentimes there is.
Okay.
There is. I mean, like I said, if you think about it, the stomach, which is made to hold acid, if it's already irritated, then they have baseline intolerance to acid and things like that, and they might have pain. Whenever we're stressed or whenever we're excited, we tend to make even more acid. So that explains why a child's symptoms might worsen during those times and they may become more obvious to the parents. But even when the child isn't having extreme pain, if they're frequently or, like I said, even consistently or even inconsistently complaining of tummy complaints, oftentimes there is a real reason for it. Okay? And especially also if the child complains of pain in an area consistently, like around the belly button or in the above the stomach area.
Okay. Well, what is the sort of medical definition for irritable bowel syndrome? You say it's a diagnosis of exclusion, which means you have to find out all the things it's not before you can identify what it is. So what is it?
Irritable bowel syndrome is really a catchphrase for pain that's due to a functional reason. Sometimes children will get, once again, a virus or an insult that sensitizes the nerves. So that normal function of the gut, like movement, gas, stretch, the passage of stool, becomes more painful. Also, sometimes due to the same insult, a child's gut can either become hyperactive or more sluggish. So irritable bowel is a situation where a child might experience pain, might have bloating, might also have diarrhea or constipation, or alternating diarrhea, constipation, or a combination of both. Those symptoms do seem to occur or worsen with stress. The treatment is really behavior modification, figuring out what your triggers are, what things cause stress, learning how to calm yourself down, and also getting used to your body's pattern. What I tell some of my patients once they're diagnosed with irritable bowel syndrome is they tend to get stuck in this vicious cycle where they might get a tummy ache because they're worried about something, and then after they get the tummy ache, then they get even more worried and their tummy hurts even more. So what they need to learn to do is calm themselves, figure out that this is their pattern. Every time I have a test, I get a little tummy ache. And so what that allows them to do is not get caught up in this vicious cycle of getting worse and worse and worse.
So say, it's normal for me to have this tummy ache. Don't be upset about it.
Absolutely. Treatment for irritable bowel, unfortunately, is really spotty. I mean, it's geared towards symptoms. For some patients, the treatment works, medical therapy. For some patients, it just doesn't. So it's more geared towards behavior modification. So it's almost like a double-edged sword. It's great that you don't have a tissue diagnosis, you don't have tissue disease or a problem, but the downside is there is no one magic bullet, there is no one treatment that works across the board for all my kids or for most of my kids, like in GERD. I mean, there are certain medicines that work or that I use consistently, and they have consistent results. With irritable bowel, it's a little bit more difficult oftentimes. But just like you touched on, it is a diagnosis of exclusion, and just to expound on that a little bit more, is what that means is you really want to exclude the things that you can't afford to miss, like an ulcer, like celiac disease, like inflammatory bowel disease, such as Crohn's or ulcerative colitis.
So once you've ruled those out, then you treat it
symptomatically.
All right.
With reassurance and in time.
Okay. I'm going to pause one more time and check for a question, and then we will come right back to you, Dr. Ulmer.
Okay.
Refreshing. Okay, we're still good on our questions. So I want to ask you real quickly about self-help measures for parents who maybe their kids are just young kids, maybe a little constipated or something, what can they do? What should they try for something like that? And when do they say, okay, we've tried enough, we got to see Dr. Ulmer?
Right, absolutely. Constipation, I'm glad you brought that up, is a fairly common entity. And children can develop constipation at different time frames. I oftentimes see toddlers who are constipated, or children who develop constipation as a result of potty training. Because I often tell my parents, you know, when they poop their pants, it's fine. You know, someone will clean them up and they can keep playing. But when you're told you can't do that, you have to stop playing, go to the potty. Oftentimes children will withhold. So that's a very common time for children to become extremely constipated.
Okay.
What I like to tell parents is natural things are oftentimes helpful. Things like fiber supplements. There are lots of formulations now that are powder that can be mixed in anything except carbonated liquids. You can't give the child too much, and basically you taper them or titrate them to the stools. On average, I like to have a child stooling at least every other day. It should never be very hard. And another important point to bring up is that even if a child does have a stool every day, they can still be very constipated. Things to look for are stooling in frequency, or if the stool is excessively hard or excessively large. Obviously, if they see blood with stooling, or if the child tells them that it hurts. Okay, those are all signs, even if a child stools every day. Okay, so definitely more natural things, over-the-counter things. Definitely avoid stimulants. Avoid stimulant laxatives, because those are the medicines that are habit-forming for the gut, and that physically and neurologically becomes dependent upon them, and then they can't go to the bathroom without them. So if it's a stimulant laxative, avoid it. Things like Miralax or Glycolax are okay. Fiber supplements like Benefiber, Miralax, those types of things are fine as well. Those are not habit-forming. Even milk and magnesia can be helpful. But as a rule of thumb, if they're having to give their child medications or supplements with frequency, meaning several times per week, and if they stop that supplement, then the child goes back to being constipated and it's time to see a specialist.
Okay, that's great. With Dr. Ulmer, I just checked my watch and I see that we're over.
Okay.
So we're going to wrap this up, but with one last comment and thanking you for being here today.
Thank you.
Remember the conference on Saturday, June 13th at 9 o'clock here at Baptist. If you're interested, please do call the register 601-948-6262 or 1-800-948-6262, and be sure and tell them when you register that you heard about it on our live webcast. Thank you for joining us today. We'll be back next month with another live seminar. You can also view the archived version of this live webcast at www.nbhs.org/mednewslive, and we hope you'll tune in again next month. Thanks for joining us.
Thank you.